Ram, shall I? Good evening and warm welcome to respected OBs and EB of 2024 and to you all dear friends to this unique second webinar on Pictorial Pediatrics, which is a brainchild of Dr. Bhavesh Nitya, who's our scientific convener for this year. For today's scientific feast, we have pediatric cardiology and pediatric orthopedics. Before I invite our esteemed speaker, I would request our dear President 2024, Dr. Ram Gopal Chezara, to say a few words. Unmute yourself, Ram.
Thank you, madam. Good evening, friends. Welcome to the second episode of Pictorial Pediatrics. Respected CIP EBs, Renu madam and Dr. Pramod Kulkarni sir. And I welcome our today's faculty, Dr. Pankaj and Dr. Taral Nagda sir. I will not take much time. I think better to start as early as possible. So over to Sushma madam.
Yeah, thank you, Dr. Ram Gopal, for those kind words. So let's begin our session. I request Pallavi madam to share Dr. Pankaj sir's CV slide, please.
Shall I share my screen?
Just 2 minutes, sir. Yeah. So it gives me a great pleasure to introduce Dr. Pankaj Sugaonkar. Sir is an interventional pediatric cardiologist from Pune. And to his achievements being a fellow in pediatric cardiology, sir is a fellow of Society for Cardiovascular Angiography and Intervention. His areas of expertise include fetal echo, cardiac CT, and cardiac MRI. He is known for his use of the latest technology. He specializes in device closure, balloon angioplasty, and various pediatric cardiac invasive procedure. He's been mentor to young pediatric cardiologists, and he's been renowned as a national and international faculty in Pediatric Cardiology Conference. With this brief introduction, I request Dr. Pankaj to take over.
Yes, thank you so much, madam. It's a nice introduction from these things. Just okay. Am I audible, madam?
Yes.
Yeah, am I audible? Okay.
Yes.
So today we are going to discuss about the pictorial guide to pediatric cardiology. And thank you so much for my IP and all the respected seniors and my friends. So we'll discuss today about, it's a great statue of a thinker that this pictorial guide is quite a new things for me as well, how to present myself in a pictorial guide. So if I make some mistake, please forgive me. But it is a new concept which I really liked when I thought yesterday that it is a really nice one that all are more interested in pictorial pediatrics. And this is a great statue of a thinker's first statue in the world, and that is a Stanford statue. Okay, so normally in a pediatric cardiology, three things are more important, like definitely auscultation, clinical examination, X-ray chest, ECG, and our rest of the intervention like device closures, balloon angioplasties, all these things. So first we'll start with the interesting X-rays, some few interesting things in the X-rays. Then we'll discuss few ECGs which are more common, and then we'll discuss how the intervention and the things will go. I will try my best with each and every slide to cover myself in these 30 minutes about the pediatric cardiology. Okay. So this is the beautiful picture. So this is the X-ray picture where actually the area has been marked for the aortic areas, SVC area, PA area, left atrial appendage area, and aortic area. Okay, this is the area where the right atrium is present. So this slide, the importance of this slide is that this is a patient sent for a echocardiography, and they said there is a cardiomegaly on the X-ray. So here I wanted to tell one very few important thing, that these are the patients of the same patient. These X-rays of the belong to the same patient. It is not a different patients. It is mean by when you do a PA view, it appears to be normal size heart. When you do the AP view, it gives a pseudocardiomegaly, and in the supine position, sometimes also the pseudocardiomegaly can be occur. So AP view that we commonly advise or unknowingly advise, so which shows a cardiomegaly on the things where there was no such a problem in the patient. So whenever it is possible, we need to just advise a PA view so that the pseudocardiomegaly can be avoided. So this is the picture, like an X-ray picture where RA, RV are there, and you can see definitely how the hearts will fit in this area. These are the rare pictures where the X-rays have been shown that such a aortic area and all these areas. So this is one of the very interesting slide. In a lateral, the right hand side of this is a lateral X-ray. In a very earlier eras, we used to do a lateral X-rays. The importance of lateral X-ray is what? You know that our right atrium, our RV and LV are not a side-by-side structures. They are anterior and posterior structures. RV is anterior and the LV is posterior one. Okay, that is the one thing. So when you do the lateral X-ray, apart from the cardiomegaly, which ventricle is enlarged, that you will come to know. So if you wanted to know the cardiomegaly is there, but if you wanted to know whether it is RV or LV, definitely you can do, or sometimes you can judge by doing the lateral X-rays. But unfortunately nowadays we could not do regularly the regular X-rays as well, and forget about the lateral X-rays too. So here also one thing is very important. This patient, you can see this, there is a cardiomegaly. The apex is going down and out. So you can here see, so which is a down and out is a picture of the left ventricle enlargement. And so here the left ventricle is a posterior structure. So the gap between the cardiac and the spinous process, definitely that gap has decreased, and which shows the left ventricular enlargement is present. Okay. Another most important this X-ray is that everyone knows that this is a figure of 3 or figure of 6 type of presentation. This X-ray classically look like a coarctation X-ray. Okay, so this coarctation X-ray is very, very important from the diagnostic point of view as well. Apart from the figure of 3 sign, there is a groove formation from the lower ribs, and these are also the classical for the X-rays. This is also the one of the very commonest congenital heart disease, like a cyanotic heart disease, that everyone knows that this is nothing but a snowman's heart. This is a figure of 8 appearance, and this figure of 8 appearance is present in supracardiac TAPVC. It is regularly or normally present in supracardiac TAPVC. It does not present in cardiac and infracardiac TAPVC, because the figure of 8, the structure formation by the pulmonary veins which are going to the innominate vein and coming back to SVC to the RA, and this lesion causes a figure of 8 appearance. So figure of 8 appearance is not only present in all types of TAPVCs, it is presently only in the supracardiac variety of TAPVCs. Okay, so that we should explain or exactly need to see when the X-ray is there. So this is the exact supracardiac TAPVC. This is a CT scan image where we do a CT scan in our regular practice whenever we have doubt about any TAPVC. Like in a TAPVC, the 4 pulmonary veins are joining a confluence, but sometimes if we can able to see 2 pulmonary veins and we do not able to see another 2 pulmonary veins, where we advise to do a CT scan in the patient. Another importance of CT scan in a cardiac type of TAPVC is that whenever the pulmonary venous hypertension is there, when we are doubt about the sizes of the pulmonary veins, sizes of the confluence, or any other drainage area, we do a CT scan in our regular patient. This is a CT scan image that is present in front of your eyes and which shows supracardiac TAPVC in nature. This is a classical X-ray. With this, looking at this X-ray, 2 differential diagnoses should be come to our mind. One differential diagnosis in a premature baby is RDS. Everyone knows that the RDS is present in such a way. Okay, that is a one thing. So, but if such a X-ray is present in a term baby, If the such a X-ray is present, a term baby, please keep in mind it is nothing but a obstructed TAPVC. So whenever you see this X-ray in a term child or near term child not maintaining saturation, okay, but it's such a time, please do a 2D echocardiography to check whether it is a TAPVC. We need to need to rule out for this X-ray. So figure of 8 is present in supracardiac, and such a appearance of RDS type of picture which is present in obstructive variety of infradiaphragmatic TAPVC, because infradiaphragmatic TAPVCs are by and rule says they are 99% obstructive in nature. Okay, so this is a beautiful X-ray like a boot-shaped heart which is present in a tetralogy of Fallot. So tetralogy of Fallot, what you can see, it is a boot-shaped heart. That is the one thing. Whenever there is a RV hypertrophy, the apex is shifted upward and outward. That is most important. Then there is a image which shows oligemia. What is the normal pulmonary vascular markings? The inner 1/3, middle 1/3, and lateral 1/3. We divide the X-rays in 3 fields: inner 1/3, middle 1/3, and lateral 1/3. So when the markings are present till the middle 1/3, that is normal. If they are restricted to inner 1/3 only, that is present in front of your eyes X-ray, that is oligemia. And if they are present up to the lateral 1/3 as well with the end-on-end appearance, these called as a plethora in nature. Okay, so this is a classical X-ray of boot-shaped heart, and it is a X-ray of tetralogy of Fallot or a Fallot types of physiology sometimes with a oligemia and severe pulmonary stenosis. So this is another most common X-ray feature. Few differential diagnoses should become to our mind. One differential diagnosis can be a dilated cardiomyopathy causing a huge heart, or it can be causing a Epstein anomaly causing a huge heart, or it is called as a pericardial effusion causing the largest effusion area in these things. Okay, so pericardial effusion, the boundaries are not clear. You can see the crisp and clear boundaries of the X-ray. In a pericardial effusion, such a clear boundaries are not present. So that one differential diagnosis is there. In a dilated cardiomyopathy, it is a uniform appearance. Yes, that is one of the differential diagnoses. And another most diagnosis, Epstein's anomaly. So how to differentiate by this X-ray to the clinical level? Epstein anomaly, multiple heart sounds are present. The multiple heart sounds are present. But in a dilated cardiomyopathy, because of LV dysfunction, there you can able to see, what you can able to see, the significant tachycardia. There is no murmur. Whenever the dilated cardiomyopathy is present, there should not be any murmur. So always we label as a murmur to the heart disease, but dilated cardiomyopathy is one of the exception to the murmur into the congenital heart disease. Okay, so 3 differential diagnoses of this X-ray is there. Now we'll coming to the ECG picture that everyone knows that this is a very commonest ECG, that is a supraventricular tachycardia. So rather than it is supraventricular tachycardia, we called it as a narrow QRS tachycardia, where the QRS duration is less than 0.08 millisecond. So how to differentiate? There is a one differential diagnosis with this. Sometimes in a regular practice, we confuse about the sinus tachycardia, where the heart rate is approximately 180 to 200. Always we versus a supraventricular tachycardia. There is so many times the ECG has been sent to me for Dr. Pankaj. Can you please explain whether it is a SVT or whether it is a significant sinus tachycardia? So one important thing we need to do in such a ECG is that sinus tachycardia, you have to need to treat the underlying cause. In a SVT, you have to manage it and then treat the underlying cause. So how to differentiate between the SVT and the significant sinus tachycardia? You know that the speed of the ECG is 25 millimeter per second. If we increase the speed of the ECG to 50 millimeter per second, the paper will move more fastly. The heartbeats gets more separated, and in such a ways you can able to see the P wave, which are not able to see because of significant tachycardia. So whenever you have a doubt about the SVT or a significant tachycardia, please increase the speed of the ECG so that you can able to diagnose whether it is a sinus tachycardia or proper SVT in nature. Another most important thing is SVT. It is a continuous in, but sometimes the sinus tachycardia also so much continuous, the baby is crying, heart rate of 180, heart rate of 200. So this is the one manuals that we regularly do on our pediatric practice, so that we can able to treat only the SVT, not the sinus tachycardia. Another most important this here is, whenever you see abnormal rhythm, we have to explain it is a wide QRS or normal QRS. Here in front of your eyes, this is the dreaded ECG picture, which shows a wide QRS in nature. This wide QRS is nothing but a ventricular tachycardia, where you have to check whether the pulse is present, whether the pulse is not present, whether the hypotension is present, whether the hypotension not present. But by and large, VT is not rarely tolerated. Okay, so VT needs a proper treatment as early as possible. And here the treatment of choice is a synchronized DC shock, that 1 to 2 gel per kg we have to give, sometimes amiodarone, sometimes Maxel, or these medicines we have to start to the patient. But shock is one of the treatment of choice in this patient. Now, in the third ECG, what you can see in this third ECG? Here, the PR interval is constant, but suddenly the P is coming in between the two P waves. Okay, two P waves. Here is nothing but a Mobitz type 2 heart block. The type 1 heart block is a prolonged PR interval. Type 2, in which the Mobitz type 1, which indicates the prolonged PR interval suddenly dropping of the beat. In a type 2, there is a normal PR interval, but the dropping in each and every beat. And the third, that is the complete heart block, where the PR interval, the PP interval, and the RR interval are same, and they are not related to each other. Okay, so this is how our CHB has been discussed. So here you have multiple P waves which are not followed by the QRS. This is a Mobitz type 2 heart block, and Mobitz type 2 and the complete heart block requires a management, because by and large some patients are definitely symptomatic. We'll come to know by my future slides which patients requires a treatment, which patients do not require a treatment. Here in front of your eyes, the ECG of the patient is present. Here the heart rate is approximately 60 to 70 per minute, and you can see the P wave here, you can see the P wave here, sometimes the P fall on T. So here one thing is very important. You have to take a piece of paper, and piece of paper you have to keep in front of the mark the 2 PP interval, and you will see all the ECG lead. You will see that the PP interval is constant, and another paper you have to take where you can mark 2 RR interval, but you will see both the RR intervals are same in nature. Okay, so whenever there is a PP intervals are same, RR intervals are same, P are not depend to the RR interval, so it means that there is a complete heart block is present. In such a patient, it is very easy to diagnose CHB in the patient. So in front of your eyes, you can see one picture, X-ray picture. What is this X-ray picture? It shows this is a newborn baby, where we have put the epicardial lead into this patient, because the abdominal, we have put the pacemaker inside his abdomen. So in a newborn baby, which newborn baby requires a pacemaker at which heart rate? First, and by large, the symptomatic congenital complete heart block babies, where they are symptomatic features of congestive cardiac failure, they are not doing well, they are having the aspects like symptoms to them. In such a patient, we need to do a pacemaker insertion in such a patient. So another most important is whether the that baby has any other heart anomalies present or no heart anomalies present. So no heart anomalies present, we can do a less than 70. If it is there, we can do. But when the heart block is present or some other abnormality is present, like a CTJ, in such a variety, we have to do a pacemaker insertion whenever the heart rate falls less than 55 in per minute. So this is a picture after putting the pacemaker in the baby. You can see the different type. This is not a regular ECG that you see in regular practice. It is the ECG. It has been taken after the pacemaker insertion is there. Okay. This is one important ECG where we can see the prominent Q waves which are present in lead 1 and AVL. Whenever the prominent Q waves is present lead 1 and AVL, V5, V6, there is nothing but our most important differential diagnosis in infantile period is nothing but a Alcapa. Alcapa is what? Is the abnormal origin of the left coronary artery from the pulmonary artery. So there is a Q waves which are present in lead 1 and AVL, because lead 1 and AVL represent the LV, and that's the reason Q waves are more present. Q waves are present in them. So here, I purposely not put the video picture, but you can see the significantly dilated heart on the echo. There is the mitral regurgitation. This is the aorta, this is the pulmonary artery, and you can see the main coronary artery arising from the pulmonary artery, causing a Al-Kappa. Okay, that is the most important. And ECG is one of the characteristic present in a Al-Kappa present. So here the normal coronary which are coming from the arch of the aorta, and here the Al-Kappa where the main left pulmonary artery coming from the coronary artery coming from the pulmonary artery. Why? If the left main coronary artery coming from pulmonary artery causes a hypoxia, because the pulmonary circulation is at the low pressure level, but the aortic circulation is at the high pressure level, so that enough blood supply does not go to the tissue and it becomes dysfunctional in nature. Okay, so that is one of the very commonest Al-Kappa variety that we have seen now. This is also one of the classical ECG in our regular practice. This ECG, if you see clearly, it is nothing but a long QT syndrome. Can you able to see the Q and T interval? This QT interval is quite prolonged. This QT interval is approximately more than 0.6, and it is called as a long QT syndrome. So in a day-to-day practice, how we go ahead with such a patient, like whenever we see one ECG and there is a long QT, we do not start a treatment. Immediately, we do not go for a treatment. What we do a Holter monitoring. Holter monitoring in which we see a 24-hour data where we call the average QTC what is present. If the average QTC is more than normal or more than the particular level, with such a cases we advise another most whether the symptoms are present or not present. In such a patient, we start with the beta blocker. So long QT syndrome is also not very uncommon in our practice. This is also a very classical ECG which shows the delta waves are present, the short PR, slurred QR, it is nothing but a WPW syndrome. So if your patient coming to your OPD with a intermittent palpitation, please go ahead for the ECG cardiac checkup, and if possible, go for Holter monitoring. It always remember that the commission is always better than omission. It is better that we see such a Holter monitoring so that we can able to see. So in Holter monitoring, we have got this finding that this patient was having a WPW syndrome intermittently, and that's the reason he was having the palpitation, and that's the reason the PR interval becomes small and the slurred QRS duration is there, complex is there. Then in a newborn practice, we'll come to the newborn level. This is now the CT scan pictures. This is a normal, this is abnormal right side vascular ring. What is meant by vascular ring? That it forms a double aortic arch, one arch coming front of the trachea, another arch coming back of the trachea, and they compress the trachea, causing the vascular ring. How you should suspect the vascular ring in your baby, if a newborn baby, in terms of no symptoms, like there was no feature of RDS, there was no another feature, something abnormal cardiac disease there. Still the baby is dependent on the ventilator. Still the baby has a completely intermittent cough cold. It is not going very easily. In less than 3-month child, you should always suspect a vascular ring. Up till now, we have operated 3 patients of vascular ring, so which shows a double aortic arch into them. So always we look for the arch vessel in such a scenario. So if your baby is not doing well, in less than 3 months, recurrent respiratory infection, not doing well, maybe ventilator dependent, always look for a vascular ring in the patient. This is another example of incomplete double aortic arch. There are 2 arches. One is normal arch, double arch, and incomplete arch. So in incomplete arch, only the one vessel causes goes abnormally, and here you can say a left common carotid artery which is going aneurysmally to the left side, because it is a right aortic arch, abnormal left subclavian artery, and in a left arch, the abnormal right subclavian artery. These are also the commonest features are there. Another most important, in my whole 12 years of practice, we have diagnosed the 2 cases of this sling. What is meant by vascular sling? Here, the LPA is coming from the RPA, and which goes completely around the bronchus and causing its compression. That is called as a vascular sling in nature. So always we look if such a patient, less than 6 months patient, coming with the recurrent respiratory infection, always I look for, apart from the heart disease, I always look for the arch vessels. I always look for whether the vascular ring is present or not present. I always look for whether the vascular sling is present or not present. Sling is nothing but a RPA. The LPA arises from the RPA and not from the male pulmonary artery. That is called as a vascular sling in nature. Can you suspect one diagnosis like in a newborn baby? You must have seen this beautiful picture. One pediatrician has, a respected senior pediatrician from Pune has sent me this picture, the baby 2 months back, and he has asked me, Dr. Pankaj, can you do this echo of this baby? And he said, I'm not palpating the femoral pulses. This patient is pedal edema. It is a hand edema. It is nothing but a Turner syndrome. So these small things we have to pick up in our regular OPD practice to do the echo of such a patient. And this patient was moderate coarctation of aorta was present. There was a bicuspid aortic wall. Then we have referred this patient for the USG abdomen to look for the renal anomaly. So small thing in the baby, always you have to have some clue in your mind. Okay, I need to check this pulse of this baby. Okay, so that is the most important picture. Always check the pulse of such a patient when you see such this thing. Another this thing is the strawberry tongue, that everyone knows that today is the day, like months or last 3 months, the more strawberry tongue, and sometimes more echocardiography numbers are there because scarlet fever is coming more in the number nowadays with the differential diagnosis to the Kawasaki. Okay, I will not go detail into the scarlet fever, but definitely I'll talk to the Kawasaki disease as per se. Here the strawberry tongue. This is a CT picture showing aneurysms which are present in a coronary arteries. So what is the best time to do for echocardiography? It is whenever you have I will explain the two scenarios here. I'll take little bit 1 minute more to explain this issue because it is common issue now in our practice is going on. Like if you know that the Kawasaki definition is that the fever more than 5 days with the associated symptoms, with the strawberry tongue, with the lymphadenopathy, conjunctivitis, rash, all these things. And in such a cases, you are really classical about the Kawasaki disease. And here you send for echocardiography, maybe because the Kawasaki disease after the 5 days. So you send the patient for a 7 days, but the coronary abnormalities are present in the second week, not in the first week. So if you have a classical Kawasaki, patient is there and still the echo report is normal, definitely you have to go ahead by your clinical acumen because the coronary abnormalities are present only in 22% of the cases in a Kawasaki disease, not in 78% of the patients. Okay, but sometimes early markers can be helpful because sometimes aortic some wall regurgitation may be there, coronary ectasia can be seen. So very few markers can be earlier present. Now I am coming to the second picture. Like this is a typical Kawasaki disease. You are not convinced in the first week about this is the case of Kawasaki disease, but the fever is still on. Still the CRP is very on higher side. In a second week, you are referring for the Kawasaki disease for echocardiography. In such a cases, this echocardiography is very, very important to you because if you can see a aneurysm formation to your patient in a second week, definitely your atypical Kawasaki disease become the typical Kawasaki disease like a feature. You are more confident about, yes, it's Kawasaki and you should go ahead. So that most important, when to refer to the cardiologist in a first week, with what intention, when refer to the second week, which what intervention. If the aneurysm formations are there, we manage them in a first week after the 2 weeks. And we give them aspirin and another manage with the 6 weeks. If the Z scores are nothing but compared to the normal age and weight and height of the patient, that maybe that 4 millimeter coronary artery size may be normal for me, but the 4 millimeter coronary artery size will be definitely abnormal for that 1-year-old child. That is, we compare with the height and weight. That is called as the Z scores. If the Z scores are more than 8, we start this patient on the anticoagulant apart from the aspirin. So always label when to refer for the echocardiography and what to expect from your cardiologist. So even if your cardiologist in the first week, if you are damn sure about this is the Kawasaki and the echo is still normal, you have to go ahead to give the IVIG and should not depend completely on the this thing. But definitely echo will be helpful to you in a second week whenever there is a typical Kawasaki disease or presentation is there. Definitely we are there in such a cases to decrease your any differential diagnosis. Now we'll coming to my third area where we'll discuss some of the echo findings. Like in echo, we always label it is situs solitus levocardia, and then with situs inversus dextrocardia, all these things. So situs solitus levocardia is liver on the right side, spleen on the left side, this trilobe lung on the right side, and this is a mirror image. So this is a situs solitus, this is a situs inversus for us. And whenever we have a doubt like a midline big size liver, it is called as a situs ambiguous in nature. So whenever you read your echo reports, always label the first line is there. Situs solitus levocardia, situs solitus dextrocardia, ambiguous variety. These actually pictures the first word of this echo report is that you should know, okay, what cardiologist wanted to say from this patient. Now, this is the echo picture. You can see this is the RA, this is the LA, this is a big gap here. You can see the red blood which is coming from left to right. Now, here the red and blue blood, I think everyone knows that the red blood is blood coming towards the probe and blue blood is going away from the probe. Here you can see a big size atrial septal defect is present in this patient. So this is a stepwise approach how we close such a holes in nowadays practice by day and day night. So we cross that hole and open the left atrial disc, then the right atrial disc, and when both the discs are in a place, we release by anti-clockwise ways and device become the part of the heart. This is the picture of the device, atrial septal defect device in my hand. Now, how the big size device goes inside the heart, that is also very important one. Here, the big size defect goes inside the heart because we completely load inside the water. So this device is loaded because there should not be some air embolism to the patient. And that's the reason we deploy this into the complete in the water area. And this is a transesophageal echo probe. This is a transesophageal echo probe. We open the right atrial disc and then the left atrial disc, and this become the part of the, we check doubly sure whether device become the part of the heart or not. Because once we do some mistake, the device will fall inside the RA or LA, and that the patient has been referred to surgery in 99% of the cases. So this assessment is very, very important when you do the device closure. Okay. Another most important here is echo picture. Can you diagnose someone here that this is the ascending aorta? I'll play this again. This is ascending aorta coming back. Here the area is very, very small. That is a significant coarctation of aorta is present in such X-ray. The most important abnormality here is the femoral pulses are not palpable. Okay. Normally, whenever we go for a cesarean section or normal delivery, we check the femoral pulses, but we do not. We should check the femoral pulses when the patient or the baby come for first follow-up, because at that time the PDA become closed and you should follow up such a patient to check femoral pulses of the patient. In my opinion, in my practice, I really advise wanted to that at time of birth you check femoral pulses, but at the age of 1 month, then 1 year, and whenever patient comes to your OPD with complaint of leg pains or claudication, at that times you should check for the femoral pulses of the patient, because coarctation not only present at the time of birth, it can be present after the sometimes childhood as well. This is a CT scan picture of the same patient which shows the significant coarctation. Okay, this is a significant coarctation. This baby has LV dysfunction of dysfunction causing a LVF of hardly 20%, and we have opened this small area by the balloon dilatation. We'll explain small balloon, how the balloon inflates outside on the table. One end of the balloon is outside the body and one end is towards that particular area where we wanted to dilate. And by deflation, the balloon becomes small, and by inflation, balloon becomes big in nature. So here is the area where you can see the ascending aorta could not be seen. This is a complete stenosis coarctation here. And you can see the severe balloon dilatation is there. And after that, it is a nice opening of the coarctation of aorta. So when a coarctation aorta, when the less than 6 month object, surgery is a treatment of choice. But whenever significant LV dysfunction, small baby, 1.2 kilo baby, this baby was 1.2 kilos with a LV dysfunction, came in emergency. And that's the reason we had to open his coarctation area to salvage him. So once he became 3 months, we had referred them for a surgical repair of the coarctation. This balloon angioplasty was the rescue balloon angioplasty, not the definitive balloon angioplasty at this age. Another most important intervention that we do is hybrid interventions. Nowadays, the hybrid interventions also we do. Like hybrid means the sternotomy done by our surgeon and the cardiologist perform the procedure. So on the beating heart, we have performed this procedure, and we did a balloon angioplasty because this baby was hardly 1.7 kilos. The significance RV hypertrophy, his pulmonary wall was significantly closed, and we have opened this pulmonary wall by directly puncturing the RV and enter inside the heart. Okay, so how we had done this? So this is the way where we can directly inflate the balloon here. Okay, so this is the area where hybrid interventions also can be monitored. One thing which I wanted to tell all of you that after the device closure or all these things, we have to monitor his age, weight, and all these things. Vaccination, definitely when the patient is sometimes on aspirin, we have to take care some aspiration when the aspirin is going on. Whenever the surgery has been happened, like open heart surgery, complete bypass has been there, we should not do vaccination for the first 3 months of age. Okay, that is most important point after the open heart surgery in our patient. So all these things are there from my side. So today we have discussed about the X-ray, normal ECGs. We discussed the same time the different heart disease as well. Another most important of this X-ray is that whenever you see the big cardiomegaly, like one patient you referred for the X-ray, for congestive cardiac failure, you have seen the big cardiomegaly is present. Now we have started him treatment because it is large VSD severe PH, but after a few times, the baby becomes improved. So every time you cannot send for echocardiography, you can simply do an X-ray chest of the patient to see whether the cardiomegaly come down or not down. Okay, that is the indirect means that your patient has benefited to the congestive cardiac failure management. It is not possible to send each and every patient for so many times for echocardiography. So we have to monitor our patients by echocardiography as well, by whether the hepatomegaly is present or not present, whether tachycardia has come or not present, not there. So all these things are very, very important in our day-to-day practice. Okay. So any questions for that? I'm welcome to it. Hope I have finished within my stipulated time.
Yes, sir. Thank you so much for that enlightening talk, sir. So we request you to wait till the second session gets over. So we take both the sessions questions at the end. Is
Okay,
that
ma'am.
okay with you, sir?
Yes, yes, thank you.
I think Dr. Sushma, if there is one or two quick question, you can take it first.
Sir, Ram Gopal, sir, I don't see any questions in the chat.
Then okay, then we'll take at the end. Yeah.
Then we can take it at the end. Yeah.
Yeah.
So requesting Pallavi madam to share Dr. Taral Nagda sir's CV slide, please.
Yes, ma'am. Sharing.
Yeah. So it gives me an immense pleasure to invite Dr. Taral Nagda, who's a renowned pediatric orthopedic surgeon. He's been attached to many hospitals like SRCC, Jupiter at Thane, Cefi at Extra. He's a director of a CP clinic and Gait analysis lab at Jupiter Hospital, Thane. And he's done a special interest in pediatric ortho, such as pediatric hip, cerebral palsy, and deformity correction. And his non-orthopedic interest are he loves gadgets, he likes farming and reading, and he does too many of the charity works. So with this brief introduction, over to you, Taral.
Yeah, thank you so much. So am I being heard?
You are audible, but your slides,
Audible.
yeah.
Okay, no, slides have come up now.
Yeah.
So today's Pictorial Pediatrics in orthopedics is about gait issues in children. And these are three passions of my life, which Sushma didn't speak about. One is walk. I love walking. Of course, I love talking. And the third thing I like is I like talking on walking. So that's why this talk has come up. And thanks, Bhavesh, for inviting, and Dr. Ram Gopal for inviting, because this is a different presentation. As Pankaj said in the earlier talk, this is more of pictures and less of words. So picture is worth 1,000 words. And I thought definitely a video is worth 1,000 pictures. And this is a common complaint from mothers that, doctor, my child is not walking properly. A lot of pediatricians face this. And one more important issue behind this complaint is, behind every mother who has this complaint, there is a grandmother who says that my child walks fine. So there are family issues here, and we need to take care of that. So the first picture or a video which I'm going to show is about normal walking. This is how all adults walk. The walking is a very energy efficient activity, and there are three aspects of walking. We must have reciprocal arm movement. Then at the pelvis, we should have very minimum movement with small oscillations. And third aspect of walking is the base of support has to be narrow. If you see a child, he defies everything. Children always defy. And that's why if you see this child walking, he's walking with broad base of support. He's walking with hardly any arm movement, and his pelvis is oscillating too much. This is how all children walk. And once they start walking, this is how they will walk till almost 3 years age. Okay, so this walk in a child is normal. If you see a 3-year-old child walking here, now you can see she's walking with narrow base of support. There are hardly any pelvic oscillation, though there is some style in her walking, and then there is a reciprocal arm movement. So now we know that the normal pattern of walking is established in this girl. Now I just want to quickly ask a quiz question, and people can reply on the chat. Is there any diagnosis which you can judge from this walking? Why did this child come to doctor's clinic? I'm going to look at the chat and see who is the first one to answer that. That's also a way of checking that everyone is awake and children attending the school. Absolutely. Dr. Bharti Kherna, absolutely right. This is bowing of legs or genu varum. And in 3-year-old child, genu varum is not normal. Up to 24 months, genu varum can be normal, but 3-year-old child, it's not normal. And you must investigate this at least with an X-ray and a reference. Okay. So congratulations for getting that right. This is around 18-month-old child, 1.8-year-old child, and this is the child's walk. This is how we record walking. When we record walking, it should be done from side and from front and back. This can be done with an ordinary mobile phone, and it should focus on the area. So you should take walking of the entire child. But in his case, if the feet were abnormal, you should also take a video of the focused area. And here we can see that this child has planovalgoid foot or a flat foot. In 1.5-year-old child, of course, this is not a flat foot, but a fat foot. And it is basically because of the fat present in the sole, the foot looks flat. And if you just observe this child is going to be absolutely fine. Okay, so flat foot in children is an important complaint. This is a 5-year-old child who complained of flat foot. And if you see this child's gait, very carefully, you will realize that this child is not dorsiflexing the feet as the child is walking. Okay, it is a slapping foot, or there is no the child is not able to clear the ground, and this indicates a neurological problem. This child had congenital sensory motor neuropathy, and after neurological investigation, this was diagnosed, which means that not all flat feet are abnormal. Flat feet can be normal when they are in a younger child. They can be normal when there is no pain. They can be normal when there is no associated gait abnormality. Okay, so it's important to see the children walking in the clinic. This is another child. This is how she is walking. And again, back to the chat here. People tell me what is abnormal in a child? Again, I am showing you that how a slow motion reception, watching the walk in a slow motion can make it more obvious. When it's in a fast motion, sometimes we may miss things, but the same walk, when I play in slow motion, and there are a lot of apps available to watch on your mobile phone, these walks in slow motion. And I'm going to go to chat again and check if people have genu valgum. No, not really genu valgum. The limb alignment is not bad. But what is very obvious here is that left leg is externally rotated. So this is an out-toeing gait. Okay, now everyone can notice this is an out-toeing gait. An out-toeing gait can be from femur or from tibia, or can also arise from the foot. And it can be completely normal till almost 10 years of age. What we do is we look at the thigh-foot angle. you make the child prone, bend the knee, and look at the angle between thigh and the foot. And if the foot is externally rotated, this problem is from the tibia. However, if you see the internal and external rotation, and if external rotation is more than the internal rotation, this is coming from femur. So in this child, it was coming from tibia. Again, no treatment required, just observation, and it became all right. Okay, so that's an out-toeing gait. Management of out-toeing gait, of course, reassurance and telling parents it's normal. It's most important, but exercises or yogas to promote internal rotation will correct it faster. So I have put two pictures here. One is Vajrasana, and on the right side is Virasana. So these are two asanas. If you ask the child to do, then parents will feel happy and child will get corrected faster. So these are internal rotation asanas which you can ask parents to do. Okay, there is another child here, and she's walking like this. Now, can people put in the chat box, what does this look like? This is opposite of what I have shown before. That's a clue I'm giving everybody. And I'm going to look at the chat box again here. In-toeing, absolutely right. This is in-toeing, and in-toeing is definitely abnormal. 15-degree out-toeing is normal, but this is too much of in-toeing. And in-toeing is a problem because if the child walks like this, the toes get entangled, and these children have frequent falls. Okay, so this is in-toeing. And how do we notice in-toeing? By this test. Again, you rotate hips internally and externally. And now we see that hips are internally rotating too much than external rotating. So this is coming from increased femoral intorsion. Again, this can be normal till 10 years age. Almost 30% of children can be in-toeing. And what do we do about that? Again, reassurance, exercise to promote external rotation. And what are these exercises? Cross-leg sitting. Ask children to sit cross-legged. So whenever they are watching television, when they are eating, when they are on the chair or on the ground, ask them to sit cross-legged. I often tell parents, buy a small table, like how, I remember my parents have studied on the ground and they had a small table at home. And if they use that table for the homework, for sketching, for drawing, automatically they will be sitting cross-legged, and that will correct internal rotation. What picture I have shown is of a asana called Baddha Konasana. And this Baddha Konasana, also popularly known as butterfly posture, in Anglicization of yogic posture, this also corrects in-toeing. Most of the time by 10 years old, this will get corrected and one really doesn't have to worry. Now, this is something which is abnormal. This child is walking abnormally. You can see there is pelvic movement, and these parents are puzzled. 2 years, these guys have been struggling from neurology opinion to rheumatology opinion. All opinions have been taken, and really they didn't know what was the child's problem. Okay, so if you really closely see the patella facing inside, so this is also a type of in-toeing, but the child is not manifesting it in-toeing because the child has grown up, has a body image, so he does not want to turn his feet. But in the whole action of not turning the feet, he ends up externally rotating the femur, and that causes this difficult type of walking. Now again, as you see here, the internal rotation is exaggerated at the hip, external rotation is legs exaggerated. And when we did a 3D CT scan, we realized that this 10-year-old child has internally rotated femur, bilateral. So intorsion of femur, 10-year-old child, not normal, and this child will require a derotation osteotomy to correct the gait pattern. So after 10 years, not normal, in-toeing, and should be corrected. A very simple sort of quiz here. And I want people to answer on the chat box, what is this? 8-year-old child. So this is Janu Valgam, knock knees, absolutely. Is this normal in a 8-year-old child? That's the second question. And again, people can type in chat box. And let's see who gets it right. Ripa is saying no, Bharti is saying no, Bhavesh Mitya is also saying no, and more no's, no, and abnormal. So this is absolutely right. Janu Varam till 3 years age can be normal. Janu Valgam generally corrects by 5 years, but in some children it can correct by 7 years. There is a paper from Sion Hospital by Dr. Binoti Shet, and it says that in some Indian children, Genu valgum can correct by 9 years, but this is something which was not normal. This is in a child with renal osteodystrophy, so definite and progressive, making child to walk abnormally. She's not able to climb stairs. Patella is getting dislocated, so this needs to be treated. And how do we treat this? One doesn't have to break the bone to correct deformities, fortunately, in a growing child. If there is a damage to the growth plate, it will cause a deformity. But the same growth plate we can manipulate to correct this deformity. And in this child, this genu valgum, we evaluated by measuring the intermalleolar distance. And we also have to look at clinically patella, because many times patella will be facing outside. So this is again showing that genu varum can be normal till 24 months. Genu valgum can be normal till 5 years or 7 years, but not beyond that. So this was treated by stopping the growth on the inner side of lower femur and upper tibia, so that growth could continue on the outer side. And with this 8 plate, this child in a year's time completely corrected. You can see the screws are diverging and the legs are becoming straight. Intermalleolar distance is reducing and her patella are centered. So she's definitely walking better. And you can see this is after the treatment. We can see that she's walking better, falling less often. And without cutting the bones, this child's bone could be corrected. We've become a little smarter now. This was a slide in 2015, the previous child. Nowadays, we don't even use plates. We use these small screws, which can be done, put through 1 millimeter incision. So no stitches, daycare surgery. Child can attend the school next day. Within a week, they can attend a dance concert or annual day or go for a football match. And this can also correct very fast, much faster than the plate. These screws will correct the deformity. So you can see instead of a year, in 9 months, this is completely corrected. And then the screws are taken out through a very small incision and the child is normal. This girl from Nashik is now state level basketball player, and correcting a deformity definitely has helped her. Some more videos again. This is a 12-year-old child and this is how the child is walking. Again, question for the chat is which leg is abnormal? Okay, is it right or left? And there is a 50% chance whatever you answer, you're going to be correct. So going back to chat, please answer. Left, okay. Left, Renu is saying left. All right. So right is not, right is right. Okay. Right is all right and left is not all right. This is absolutely right. The left side is abnormal. And how do you make out? 2 things. That child is bearing less weight on the left side. That is how you know. Secondly, the child is keeping the hand on the left thigh to reduce the pressure on the left. Okay. We also notice that there is external rotation in the left side. So left side is definitely abnormal. And this child had pain going to the knee. Whenever you have pain going to the knee, always look for the problems in the hip. Whenever there is pain in the shoulder, we look for cardiac problems. Pankaj, knows about it, being a cardiologist. So whenever there is pain in the knee, always look for a hip. So this child had a MRI of the knee, X-ray of the knee, but nobody took X-ray of the hip. And this classically shows what is known as slip femoral capital epiphysis. If you see here, the neck of the femur, very clearly the head is slipped. One must rule out endocrinological problems. And this was again treated percutaneously, detected well in time, just with a single screw. And this child went back to walking and being normal. This is an 8-year-old child. And again, I'm not going to ask, but the right side is a problem here. It is in abduction. It is child is putting less weight. The clue here is this child had night pain, which responded to ibuprofen. So if that is the history, night pain, and then you are somewhere away, the parents send you this video and they said, sir, रात को दर्द होता है और जैसे ही ब्रूफेन लिया दर्द खत्म हो जाता है, कुछ भी नहीं है there. Then what will be the diagnosis? Let us see if anyone remembers this. And yeah, so Pramod says it could be leg hip effusion. Absolutely. From the gait, it could be a transient synovitis of the hip joint, because in abduction there is more capacity to the hip, and it could be reactive arthritis, absolutely right. But a long-standing pain, more than 3 weeks, rule out leukemia. Bhavesh, you are absolutely right. Night pain, remember malignancy. But night pain which responds magically to ibuprofen would be osteoid osteoma. Okay, so this child, we did an MRI. MRI is not the right diagnosis for osteoid osteoma because it will just show marrow signals. And again, marrow signals could be leukemia and many other things. But a CT scan here, you can see it picked up this big nidus in the acetabulum. So this was osteoid osteoma. And anybody knows what is the treatment of choice? Who will treat this? A radiologist or a surgeon? Anybody? Put it on the chat again, and let's see if somebody can get it right. The treatment of osteoid osteoma, absolutely. The radio knife, Bharti, you're absolutely right. Also known as radio frequency ablation. You don't need to operate these tumors. You just burn the tumor with radio frequency ablation with a CT scan, and they will be absolutely fine. So osteoid osteoma picked up on the gait and a history and confirmed on a CT scan. Okay. This is a 3-year-old child, and this was related to one of our pathologists in KEM, I remember. And this is how she's walking again in slow motion. You can see that, clumsy gait. This is a typical waddling gait. And when you have a waddling gait in child, what bells does it ring? Waddling gait in a child, what would be a most common diagnosis? DDH, Bhavesh, absolutely right. So you must take X-ray and check that hips are normal. Unfortunately, though she has a clumsy gait, all her doctors said that, nothing is wrong. Some children are like that. Whenever such symptoms exist, it's important to examine the child and get hip X-rays. And this clearly shows this child had bilateral hip dislocation. And it's very important to screen children with DDH. So if you have a torticollis or a club foot or metatarsal adductors, one must look at the hips. And I'm just going to show these videos very quickly to show what is Ortolani's and Barlow's test. This is a revision. So this is Ortolani's test. You abduct the hip, and all of you can see as I'm abducting the hip, okay, with the child relaxed, now the hip is reduced. There is a clunk of entry. Ortolani is underlani. So any test which gets the hip inside is Ortolani's test. And then we have Barlow's test. Barlow's test is the hip is inside, but you provoke it to push it out. So any test which gets the hip out, bahar lao, is Barlow's test. So you have Ortolani's test and Barlow's test for hips which are dislocatable or dislocated. And it's very important that hip dysplasias are common. And we are very happy that Pediatric Orthopedic Society of India and IAP are working together on a lot of pathways now to increase awareness about DDH, doing screening tests. And we are seeing more and more children with DDH. In fact, I had last week 3 children less than 6 months diagnosed by pediatricians on basis of this test who were referred for early treatment, whom we could treat just with polyc harness, home-based polyc harness treatment. Unfortunately, this child who was 3-year-old required major surgeries on both the hips, and now is she doing fine. But the moral of the story is DDH should be detected early and treated early. So it is a collaboration between pediatricians and orthopedic surgeons to treat this. Coming back to one more gait pattern, can anyone tell me what is this gait pattern? Again, seeing in slow motion. You can record in slow motion on many mobile phones or watch on slow motion. It always helps. So I'm just checking the chat and let's see what people have to say. Tiptoe walking, absolutely, Bhavesh. Toe walking, Renu, absolutely right. So this child has a normal developmental history and no other problems. Okay, tone is normal. Milestones have been fine. So there is no indication of a neurological problem. When that exists, we label this as idiopathic toe walking. I remember in KEM, Dr. Manu Kothari used to tell us that when the diagnosis is idiopathic, either doctor is idiot or patient is pathetic. Here, neither the doctor is idiot, it's an intelligent diagnosis, and patient is walking and not pathetic, but this is idiopathic toe walking. And when you have normal milestones, most of these resolve. In fact, if you ask a question, many times the father or the mother may have had toe walking and that has resolved. In some children where ankles are tight and calves are tight, it does not resolve. And then what we do is resolve them by surgically elongating the calf muscles. Nowadays, fortunately, we don't need operations for doing it. With a small needle under ultrasound control. We are able to lengthen the calf muscle without any stitches as a daycare surgery and make these children to walk on the heels again. Okay. Now this is a tricky one. 6-year-old child walking on toes, but when she starts walking, she's on heels. Only when she walks further, she comes on toes. And she's an autistic child. So cognitive problems also can give rise to toe walking, and they don't need surgery, they don't need Botox. And they require is behavioral therapy and occupational therapy to correct this issue. When there are spastic muscles and children are walking on toes, the diagnosis is different. This is cerebral palsy. So you can see this child is walking on toes. There is scissoring on the right side. So this child has calf spasticity, hamstring spasticity, and adductor spasticity. And this many times requires controlling the tone locally with help of botulinum toxin injection. So we give this under ultrasound guidance, and this is given again as a daycare procedure. And in many children, at the right time, if these injections are given, the tone will reduce, hypertonia will reduce, and you can see that the same child is able to now walk on the heels down, walk without scissoring, is now trainable by the physiotherapist to walk normally. And many of these children will walk well and do well with this simple treatment. When children with cerebral palsy grow old, this is a child who is walking on toes on the outer border. She's being carried by the mother. You can see the father is standing with a folded hand outside as a spectator. This is a typical Indian scenario, family scenario of cerebral palsy. And there is no hope for this child. How will she go to school, study, be a useful member of society? So for these children, now we have again a ultrasound guided procedure. So, some similarity between what Pankaj is doing and I am doing. Pankaj is doing all percutaneous procedures for the congenital heart surgery. And I am also doing a lot of percutaneous procedures for pediatric orthopedic problems. So under ultrasound guidance, Pankaj, the same machine we use, which you use to diagnose congenital heart problems, we use a needle to release the tightness in these muscles and make the muscle elongate, without doing an open surgery. And this is how this is done under ultrasound guided. So this is not echocardiograph. This is a calf muscle, not a cardiac muscle. We are releasing with a needle, and we can measure the release. And these children can walk better. So now she's walking on her own, walking with heels down. She's able to go to school. And I really wanted to, show this in presence of our president, Dr. Ram Gopal, that if you see this video, the mother is free now, and father has hope, and now he's looking at the child. Probably she's going to do better in life. So that's the family sort of aspect of any pediatric disorder, which is very important. We can't forget our parents. There can be, disputes when you see a child walking, see it with naked eye, because our eyes have limitations. So what do we do? As my previous speaker showed, the modern investigative approaches to heart, ECG and then echocardiography and other modern investigations, we can also scientifically measure walking. And that is done with help of a 3D gait analysis lab. So what it has is, it has 8 cameras. You put markers on patient's body, and infrared cameras pick up those markers and convert that information into graphs. So for example, this is a child with cerebral palsy. And if I take a video with a normal camera, this is how it will look. That this child is walking with knees bent with a crouch gait pattern. But if you see on the bottom, the analysis or the animation is something which is seen by the 3D gait analysis camera. We can measure pressures, we can measure angles, and we can do this in X, Y, and Z axis. So we can actually measure What is abnormal with the child's walking? Which muscles are spastic? What is causing the issue? Is it a bony issue, muscle issue? What kind of problem is present? And then correct it. And then it allows us to take a right decision. And that child, we could make him to walk completely normally. It's very difficult to now even make out that this child had any problem by doing a percutaneous hamstring lengthening. So gait analysis is something new. There are few gait labs already present now in Maharashtra, where you can refer your patients in case the child has walking issue, and we can scientifically measure and document it. So coming back to my last pictorial presentation, I know everybody is post-dinner, and this is a dessert being served. So whenever there is a knowledge, it's possible to share knowledge through these activities. There are many platforms, but what is important is something else. If you don't share dentures, that you cannot eat a chocolate. So there are many conferences, presentations, there is a message. But what I would say, if there is no picture, then there is no penetration of knowledge. And I congratulate Maharashtra IP again on starting this series on pictorial pediatrics. I hope everyone enjoyed today's presentation, learned a little bit from it. I have enjoyed it quite a bit, and would like to come here again on the platform. Thank you very much.
Thank you, sir. I think today's both the sessions were phenomenal. मैंने 1 मिनट भी आंख नहीं झपकाया है स्क्रीन से. It was that good.
Thank you.
Yes,
Thank you.
madam.
Thank you, Taral. Wonderful presentation. And there is a question for you actually. Can it be correlated with PGALs?
Can you repeat the question?
Yeah, so can it be correlated with PGALs? PGALs is the examination for the musculoskeletal system. So what?
Yeah, absolutely. So any gait analysis is incomplete without a clinical evaluation. So clinical evaluation is the first part whenever child comes with a walking abnormality. So typically when a parent would come to me that my child is not walking properly, first thing we see is child walking. It is very, most of the time, the cabins in our corporate hospital rooms are so small, it's very difficult to see the child walking. Child also gets cranky and doesn't walk properly in our consulting room. So I come out and see the child walking in the corridor. That's a very important thing. And then we examine the child clinically. Clinical evaluation is important.
One more question. Is intraosseous lipoma is harmful?
Intraosseous?
Osseous, I think so. Yeah, it's an interous. INTERROUS.
Intraosseous.
Intraosseous. I thought intraosseous, but
yeah. No, I have not come across this condition, intraosseous lipoma. But if there is a lipoma in the spinal cord, if it's part of spina bifida, then definitely that child needs to be seen, to be investigated, to be seen by a pediatric neurologist and treated. So if I come across a child who has a lipoma on the sacrum or a lumbar region, that it is something indicative of a problem inside, and that I would at least investigate by doing an MRI.
So your comments on a W-sitting.
W-sitting. So W-sitting is not abnormal. There are a lot of things which are malign in a child's lower limb. Flat foot is malign. Okay. Similarly, W-sitting is malign. W-sitting is just an indication of femoral intorsion. Children who walk with in-toeing will also sit with W-sitting. What is required is to balance W-sitting with cross-legged sitting. That becomes a balancing posture. So W-sitting is not bad. In fact, in yoga, I've just returned from my yoga class, so I can tell you Virasana and Vajrasana, they are type of W-sitting, and they are considered to be, warrior poses. Virasana means it gets you a lot of energy. A lot of meditative practices are done in that posture. So how can it be bad? So W-sitting is not a problem.
So do you have any handbook for regional exam of a musculoskeletal system stroke joint in children?
But I think it's a good suggestion. At present, we don't. There are examination books for orthopedics, but I don't think they will serve the purpose of a pediatrician. So I think I take this as a homework for me, and maybe with Bhavesh, we can write a small monogram on orthopedic evaluation point of view of a pediatrician. We can make a PDF book, and maybe through Maharashtra IIT we can share it to all the members.
Infographics can be made, single to
Infographics can be made, absolutely. So let's come up with a book in 3 months' time, Bhavesh, and let's see if we can do that. Or at least by
Wonderful.
next Pedicon, we can make a book and release it.
Wonderful.
Good suggestion.
So actually a question from my side, Taral, to you, that when should we refer a case of a CPQ for a gait analysis?
Absolutely. So first of all, gait analysis cannot answer if there are no questions. Okay, this is something very important. You must have questions to ask if gait analysis has to provide answers. Gait analysis can be done only for children with cerebral palsy who are walking. You cannot do it for children who are not walking to find out why they are not walking. Gait analysis can find out abnormalities of walking. Is there equinus at ankle? If there is a problem in knee joint, problem in the hip joint. So we do gait analysis for children with CP who are walking children, but who are abnormally walking between age of 5 years plus. And we do it for these children generally before an intervention. When I use botulinum toxin, or when I'm going to operate, or when I have to decide what orthosis of splint to use for these children, when I have questions in mind, that time we use gait analysis. It is not done as a day-to-day evaluation for every CP child.
And you have shown us the correction with the deformity. So how long it takes for a child who undergoes a surgery to return back to a normal?
Right, absolutely. So there are different norms. There are children factors, and then there are uh, uh, factors related to the procedure. Now, when the child is growing fastest, the deformities or correction is also fastest. If we see the growth of a child, there is something known as acceleration phase of growth for lower limb, which is between 9 to 11 years in a girl child and 10 to 12 years in a boy child. If we do correction before that, it is very slow, and there is a chance of recurrence. When we do correction in the fastest growth phase, the correction is also faster. When the growth becomes slow, the correction are slower. In a girl, typically once menarche is achieved, you will the correction will not happen. In boys, you don't have menarche to judge somehow. But a good indication of when the growth correction will be fastest is to take X-ray of the elbow joint. And on X-ray of the elbow joint lateral view, if the olecranon is open, olecranon apophysis is open, that's the best time to correct the deformities with a growth modulation. We call these techniques as growth modulation. Again, we have realized that screws correct faster than plates. We have realized that growth plates which grow faster will correct faster. So we say that towards the knee we flee and away from elbow we grow. That's the dictum which we have read in anatomy textbooks. So up lower femur and upper tibia, they correct faster. The hip and ankle do not correct that fast. Similarly, elbow corrects very slow, but shoulder and wrist will correct very fast. But roughly it takes around 6 months to a year for correction to happen. Nowadays, we are using these techniques also for correcting limb length discrepancy. So if one leg is longer and other is shorter, we don't have to do this Russian techniques, and which is known as a legal torture of a child, because they have to be in this limb lengthening apparatus. We put these screws or plates and stop growth of a longer limb. So for hemi-hypertrophy, we now stop the growth of a longer leg at an appropriate time using these screws, and both legs become equal by the time child is mature. So I hope that answers the question. How long does it take?
So
Can
thank
I
you so
ask a question, sir? How common is our nursemaid's elbow or this thing?
Yeah, very common, very common. It's so common, and then many
And
times it recurs.
it is very rewarding when an orthopedician just have a knack of going it back,
So
and the
what
child
happens?
becomes
Yeah.
painless.
So when I speak about pulled elbow or nursemaid elbow, I always tell my residents, or when I speak in a conference, don't send these children for X-ray. The reason is not that you want to save X-ray money. To take the X-ray, the radiologist will straighten the limb like this,
Yeah.
and that reduces, and immediately the pain goes off. So the reward you would get as a doctor of treating the child and making the child pain-free goes off. So first reduce the pain, the pulled elbow, and that is simply done by making the palm go up, supinate the arm and extend the elbow. The pain will immediately go. Second, instruction for all pediatricians is give anti-inflammatory for 2 days, not paracetamol, ibuprofen, because there is the radial head comes out of the annular ligament. Once you reduce it, it is still sore, and child is not that happy. So if you give anti-inflammatory for 2 days, the child will be back to normal activities much faster. And third thing, you must tell the parents that don't let anyone pull this child's elbow, because these are all children with ligament enhanced laxity, and there is no reason why it will not come back again. So, with these instructions, you let the children then take care. I have mentioned this on my blog. I have a blog, and again, on my website, which is ipodindia.org. If you type Taral Nagda and pulled elbow, I've put a complete manual of how to reduce it, and there are videos and pictures of how to do it. So you can go through it, and in case of emergency, just remember this blog, go through it, and so then you can treat it wherever you are. You don't have to refer to an orthopedic.
for the
Right, sir.
questions for Dr. Taral.
Maybe if you have a time, one more point on how to differentiate fixed flat feet versus dynamic flat feet.
Yeah. So I didn't cover it. I thought wanted to face, but I'll tell you a very simple thing. You ask the children to stand on toes. When they stand on the toes, if the arch is seen, that means it's a mobile flat foot and it doesn't require treatment. If it doesn't correct when they stand on toes, if the heel is in valgus, then those are, or if the flat foot is painful, so those are indication that this is a fixed flat.
And at what age we define the child as having a flat feet?
Decide what? Decide.
At what age we define or confirm that child to have a flat feet? 7 years, 8 years, 9 years, 10 years?
So absolutely. So there is no fixed time, but till 5 years, many children will have flat looking feet, and it's not a concern. But any child who has continuation of flat feet, which is painful beyond 8 to 9 years age, that requires to be seen. Previously, we always used to say that the treatment is through exercises and and the modified shoe wear or an arch support really doesn't help, which is true. But nowadays we do see very severe forms of flat feet, which are symptomatic. And there are now treatment methods available in form of small arthrolysis plugs. There are plugs which we put at subtalar joint through one stitch, small surgery, which stabilizes subtalar joint and correct the flat feet. So there are children with flat feet who have what is known as subtalar instability. So sometimes we identify these and treat them early, so that those flat foot don't worsen. So from 100 flat foot, if I see, there'll be around 5 or 6 who have subtalar instability, which actually require management, which are again asymptomatic, which again form an arch when the child stands on toes. But when you see them walk, they walk with horrible looking, which are not corrected in footwear. So those are the ones which require the simple surgery at around 12 to 14 years age.
Well, the last question for you. How to stabilize or treat the rotator cuff shoulder injury in 12-year-old child?
So many times, rotator cuff, many injuries in adults we don't treat in children. One of them is patellar dislocation. Patellar dislocation in adults is always treated with arthroscopic surgery. In children, it cures. Similarly, a rotator cuff tear in a child many times can be treated conservatively and it will heal, which doesn't happen in old. So if you have a grandmother who has a rotator cuff tear and a granddaughter who has rotator cuff tear, the grandmother will undergo an arthroscopic repair, but granddaughter most often will not require any surgery.
Thank you so much. Any questions for Dr. Pankaj? Pankaj sir, you are there?
Yeah, Pankaj is
Sir,
there.
unmute yourself.
Yeah, tell me, ma'am.
Sir, I just wanted to ask you, sir, you said you have done so much of an intervention cardiology. So when this intervention in cardiology has been evolved, so how did it evolve? I mean, what advantage when it started having? People were for it, not for it, had so much worry about the intervention. Means how did it got evolved?
Actually, it's a very interesting one because pediatric cardiology interventions last 15 to 20 years, 15 years in right now in our country that we're doing the interventions. It is a very innovation over the period of time. It has not happened in a one day because the newer devices has come into the place. Recently, the premature PDA device also came from USA, like a FDA approved device has came into the market. And over the period of time, we also got a very good hands-on experience over the period of time. Our beauty of our country is that we have significant number of cases. So that's the reason we become much more trained early than the any other people because we do a lot of number of cases. Like up till now, we did more than 3,000 pediatric cardiac interventions now with a zero mortality. So we got a very good training across our institutes, very good numbers. Also, we got another training after different institute as well. Because unless and until you work for more than 2 or 3 institute in your super specialty areas, so unless and until you are not that confident to do the interventions. So also this pediatric cardiology requires not only 2 year or 3 year training. Sometimes it requires a training more than another 2 years, like approximately 5 years. I have taken a training in pediatric cardiology, and then I started my practice in Pune here. So we got a good hands-on experience. Our teachers were good because of the field was very new. Our teachers were absolutely very supportive to us. And over the period of time, some of the government yojnas and all these things help us to do a more number of pediatric cardiac interventions. And the new innovation also going on, like earlier I said, that US, all the new pictures are there. And with the help of out of India conference as well, in India conference also, we got a very good insight into the things. Because intervention is like you cannot think while doing the interventions, you have to perform. Either you will be 100% successful or you will be 0% successful. So there is not in between one. So at that point of time, your reflexes has to be very quick and fast enough. You know what to do within a fraction of a second because the baby will not give that much time to you to recover, think over it. So over the period of time, with a lot of numbers as our country, lot of patients are there. So we got the good hands-on experience. Another most important is that the intervention beauty is that within a 48 hours, the patient goes home without a scar mark in over his body. So that is most important. The parents, whether it is a female child or whether it is a male child, for female child parents, it is absolutely, I can say, it is a very good thing for them, like a God gifted thing for them, because there's absolutely no mark on their body. Because if you go for open heart surgery, there is a completely big scar over their chest, and that causes us all social problem to them during their marriage life, all these things. So when our patients also see our interventions, their numbers, their success, and definitely they come forward and ask to more number of cardiac interventions as well. So that's how we develop over the period of time. Thankful to our teachers, the development, maybe inside and outside India, as well as our beautiful patients. We are given them us a very good experience as well as the hands-on experience.
In your experience, anytime device closure, you had to go for an open heart?
Sorry,
Some
ma'am.
problem? In your experience, you done a
Yes.
device and you had to go for an open heart, something had
Yes,
happened
absolutely,
like
ma'am.
that.
That each and because every time you cannot accept flowers, sometimes you have to have a thorn injury as well. So while accepting flowers, I think we should prepare for that. So, but we always prepare. We do intervention whenever there should be a surgical backup in our cases. We anticipate all these issues, like which patient is more critical one. There is a 1% chances of device embolization requiring a open heart surgery. But in our more than 3,000 cases, only 6 of our patients requires us open heart surgery because of device embolization, and our 99.88% patients are doing absolutely very good. So hardly 0.12% or 2% complication rate is there, but we always keep our surgical team to a standby. And most of our institutes in Pune and Aurangabad, they have a surgical standby, and they have our cardiac surgeons always help us for the round the clock to our patients. But definitely, but after the device embolization, not a single patient we had suffered for heart block, and not a single mortality in our case in last 12 years, though we have operated from more than 1.1 kilo baby.
That is really great work, sir. Ram, you wanted to ask something?
Yeah. Sir, you said that sometimes you involve the cardiothoracic surgeons, you do the open the chest and then you do the procedures. So can you just name what are the procedure where you require help of a cardiothoracic surgeon as well? You form a team and you do the procedures.
Yes, thank you so much for this very important and beautiful question. That this is a hybrid. This is called as a hybrid word. So
Yeah.
you mean that my patient, I did 2 hybrid interventions here in Pune. So one patient was a 4-month-old with a weight of 3.5 kilos, and he was having the mid-muscular VSD of approximately 12 millimeter. Okay, so either I have to go for a cardiopulmonary bypass by the cardiac surgeon, where he completely go bypass, completely heart is stopped, everything cutting, everything there. Or if I wanted to go by intervention route, I have to put a bigger size of the sheath, because whenever the that VSD is bigger in nature, we have to put bigger device. If you want to put a bigger device, you have to go with the bigger sheath as well. But in a 3-kilo child, that bigger sheath could not pass. So whenever we have restrictions, and still we can able to do such a cases where our surgeon's team is standby, they open it, we directly put the device. Here the advantage is what? There should not be need to stop the heart. There should not be go to the bypass. And also, if any problem is there, surgeon is at the side of you. So in our surgical patient, that hybrid VSD device closure patient, we directly deploy the device, come out, waited for 5 minutes, and while coming out, our surgeon take a very small suture over the RV. So after this, our patient, we immediately shifted to the ICU, and within 3 days, the patient shifted to the ward. So there is no need to stop the heart. There was complication of bypass has been completely avoided, and the early recovery is there. But that disease has to be deviceable. That is the first time. Okay. So in between cases of surgery and in between cases of intervention, we go for this. Another hybrid interventions which are performed in that is a 1.2 kilo baby, which has a severe PS amounting to the atresia. His PD was closed. His significant RV hypertrophy. We try to go for the transvenous like IVC RA to RV by the small wire, but the wire also could not pass because it is significantly hypertrophied heart. Because at the time of birth, if one wall is closed, the ventricle below before that it always get hypertrophied. Okay, and that's the reason it could not pass a wire. So in such a cases, the patient was in pericardial effusion as well. In such a cases, we open it, directly puncture the right ventricle, pass with the wire, and over the wire we have taken the balloon. So immediately this saturation went from 50 to 95% on the table. So that is a 1.2 kilovolt. And over the period of time, the baby improved. Within a 10 days, the baby improved. We discharged the baby. Last few days back, last year, again I did his balloon pulmonary valvuloplasty because he was 9 years old. So by the day of 15 days to the 9 years, he was completely fine. Again, his wall became closed, and last year only I opened his wall. So that baby is approximately 10 years now. So in borderline cases, we definitely go ahead and do this job. So advantage not to go for a surgical, because surgical needs a bypass. Whenever the patients are critical one, they do not tolerate a bypass in nature. So that is also one of the things where we go by the hybrid route. So advantage of hybrid route is early recovery, as well as if any complication can happen, the surgery is there to stand by. So that is also the good advantage, that the team is there with you, and you have to just perform the procedure, but you have to be very good at doing the procedure and doing the echocardiography simultaneously.
Okay. Thank you, sir.
Yes, thank you, sir. Thank you so much.
Just a last question. How do you approach a pulmonary hypertension? Because it's in a cardiac lesion and a role of a sildenafil and bosentan.
So pulmonary hypertension, there are different causes of pulmonary hypertension. Whether the pulmonary hypertension is because of left to right shunt, we do not give a sildenafil, because here the pulmonary hypertension is kinetic in nature. In such a patient, we treat the cause, underlying cause. Another, I will tell you, the idiopathic pulmonary hypertension, where the no cause is present, only the idiopathic pulmonary hypertension is there. The causes can be, the patient can have a HIV, patient can have a SLE, patient have a interstitial lung diseases, patient can have some abnormal lung issues, patient has some interstitial problems. In such a cases, the idiopathic pH is there. In such a cases, we start with the sildenafil 1, and then if it not respond to sildenafil, we can add a bosentan to that patient, and then afterward the selexipag. So this line goes up. Now another one is intermittent. Like I have only 5 millimeter ASD and my pH is 120%. So I am dealing with the idiopathic pH, though my ASD is 5 millimeter, because 5 millimeter ASD will not cause 120 pH. So in such a scenario also we give a assurance or sildenafil or bosentan to the patient. Firstly, we decide the cause of the patient. Then we give. And sometimes whenever like a 2-year-old child with a large VSD, severe pH, the mother and father got late to the treatment, the child developed hypertension. But if you wanted to give them a surgical care, sometimes such a cases we start the sildenafil 3 days prior to the surgery, so that immediate postoperative problems can be regularized or maybe minimalized over the period of time. So that is the way we add a sildenafil and to the bosentan to the patient, not completely left to right shunt patient. Now what happens is very few scenario, like my child is 3-month-old, but his VSD is completely right to left shunt. But at this point of your time, I cannot imagine that it is a completely idiopathic pH. Sometimes it can happen that the normal pulmonary vascular resistance, which was present at the time of birth, which has not come down. So yesterday I have seen one patient, that patient was 3-month-old, VSD was completely right to left, the saturation was 50%. This patient was not a Eisenmenger patient, this is just a 3-month-old patient. So I have started the amount of sildenafil to come down his PVR first. So I'll try with the medicine first and then I will investigate him further. So this is the way where we should start the sildenafil and where we should not start a sildenafil.
Absolutely. Thank you so much for that thorough insights. So
Thank you.
any other questions from any other delegates? So I think we just had a brainstorming session with the pediatric orthopedics as well as the pediatric cardiology. So it's a time to say thank you to everyone.
Thank you.
So thank you to both our esteemed speakers for such a wonderful insights of such a lovely videos and such a wonderful things. For you, Pankaj, I have jotted down the key messages, your lateral view and everything. I put on the important take-home messages for me. I extend my gratitude towards the EB member of a central IIP, then OB and EB of our Maha IIP. Last but not the least, all the attendees who are there with us till now. It's almost 10:30 past and we are still there to listen to you, all of you. And then our Pallavi madam, who's our technical support, and Dr. Vishal Raut, who's our technical visa. So thank you so much. Thank you once again.
Thank you, IIP, and thank you so much, madam, for your nicely conducted. I have seen you while presenting that you are writing down some points. I think I should also learn from the things like so fastly that you are picking down the points and remembering them. Thank you so much and wonderful. I enjoyed with you all, with my pediatric colleagues, teachers, my respected friends. My heartfelt thank you to all of you. Thank you.
Thank you. Yeah. Good night.
Good night, sir.